Okay, so this starts the third and hopefully final section of Learning Plan 1. This is kind of where I left off, and we were talking about culture and different practices that people have, ways of thinking about illness, especially mental illness, and we started talking about immigrants, refugees, and cultural minorities as really being at risk for getting inadequate care, especially mental illness care. And down at the bottom of this slide, it says we may assess some cultural patterns that may support or interfere with the process of health and recovery. What can you do? So, this really is a realistic problem that you're going to face in your practice, no matter what area of nursing that you choose to work in. Maybe some of you have already had different types of experiences with people that come from a different culture. Page 86 and 87 in your Varkarolus book really does a very, very nice job of talking about how the nurse can gradually become more and more culturally competent, and that really it is a growth journey to be able to work with a person of a different culture. And they go through the different steps of cultural awareness, cultural knowledge, cultural encounters, developing cultural skill, and having cultural desire. So that really means that the nurse, when you get to the end, when you achieve cultural desire, it really indicates the nurse is not acting out of a sense of duty, but really from a sincere and genuine concern for the patient's welfare. Page 87, they also talk about how there are like three different ways to think about somebody's cultural practices, because some patients take different types of herbs, they may have other types of home remedies, and some of the home remedies and especially herbals may actually be interfering with the Western treatment. So it really is good to become aware of those. There might be other types of treatments such as coining and cupping that are typically performed with Asian populations. However, those are probably neither helpful nor, they may be helpful, but they probably are not a hindrance to Western medicine. So things that are helpful, things that are not very helpful, like actually detrimental, or things that are neither helpful nor detrimental. They're kind of neutral. So there's kind of three different ways that we can think about some people's cultural practices. And then what do we do if somebody has a cultural practice, say they're taking some kind of an herbal supplement that actually interferes with their medication or is just really harmful with whatever illness they have going on. And that's a point where you really try to get at, it's always good to ask a patient, what do you think? How do you feel this is going to help you? What does this do for you? What do you think? What does your family think about this treatment? And then try to negotiate with them is really the best thing to do. Try to provide some teaching and negotiate with them. And certainly if they have other cultural practices or practitioners like faith healers, we certainly should be involving them as much as possible, because then the patient might feel really supported in their own culture if they're allowed to have in a faith healer. This has happened several times on 1K where we've had a shaman come in and they perform a healing ceremony, and even including lighting a fire. And of course, it has to be done in an area of the unit where there aren't smoke alarms. There's always those practical considerations. But if the patient really feels it's very helpful for them, then we really should be going along with their, with their desires. Years ago, I had a really interesting experience working with a very young Mennonite gentleman, and he was probably about 17 or 18 years old, and his family had the view that his symptoms were caused by his sinfulness, and if he wasn't a sinner, then he wouldn't be experiencing these symptoms. And when he came to us, he was very, very thin, and he really hardly said a word. He was almost mute, just like nonverbal, not giving us eye contact. So we, after assessing him and kind of getting a feel for him after a few days, we really determined that he more than likely had a form of schizophrenia and possibly an eating disorder on top of that. He really was like very, very thin, like dangerously thin at the point where we had him. And his family was saying that he wasn't eating or drinking. So he had a couple of things going on, but we really felt it was more of a psychotic process going on with this young man. And we could not convince the family that it was not his sinfulness. And we started him on medication, and the family didn't object to him being on medication, and he actually did get better. He improved quite a bit. He still had kind of a flat affect. He still wasn't terribly verbal, but he was more independent, taking care of his ADLs. He started to eat and gain some weight. So he really looked pretty good by the time he left our unit. We allowed the family many times to have healing ceremonies. They called in different people. They had guitars and all kinds of people playing instruments and singing and, healing ceremonies. And it was really sad, though, because by the time he left, he was doing quite well. And we certainly were teaching and encouraging the patient to continue not only with these healing ceremonies, but also to take his medication. And then we found out a couple months later that his parents basically stopped giving him his medication, and they were just using the faith healers, and this young man actually died as a result of his eating disorder. So it was kind of I guess we felt like it was kind of a fail, although we tried really hard. We all read books that they gave us about the Mennonite faith, and so we all really felt like we were educated and we kind of understood their beliefs and their values, and we really tried to support them. But it was just difficult for them to accept our version of why he had this mental illness, and they really just could not back down off of the idea that his symptoms were sinful. So, sometimes things happen like that. It's really unfortunate, but cultural and religious beliefs are very strongly held sometimes. So trying to do some negotiation is really a helpful thing in many situations. Okay, Chapter 6, Legal and Ethical Considerations. So it's a good thing that we have legal tenets that we go by and ethical tenets that we use when we're thinking about difficult situations. So there's lots of things that could be considered controversial, such as suicide. Some people think that it's a person's right to commit suicide, and other people, of course, are very set against that. And truly, as a medical professional, mental health practitioners are against suicide. We certainly would not encourage anybody to commit suicide. But there are other, we've all heard about assisted suicide situations. So in our society in general, it can be considered a little bit controversial. So we do have to look at legal and ethical guidelines when we're trying to think of these difficult situations and to help us make the best decision possible for the patient. So just ethics basically is the study of basically what's considered right or wrong in a society, and bioethics is basically what's right or wrong related to healthcare, and it kind of helps us with dilemmas. And that ethical dilemma is something that's a conflict between two or more courses of action, each one with favorable and unfavorable consequences. So that's kind of just a little bit of a background and just some principles of bioethics. And you may have heard these words in other settings. Beneficence is the duty to promote good. So basically that we should always be trying to do good for the patient. Autonomy is respecting the rights of others to make their own decisions. So that is something that's kind of difficult when we think about, again, people that are wanting to commit suicide. Should we respect their right to not live their life the way they've been living and to end their own suffering? So there's where it gets to be a little bit of an ethical dilemma when we think about that autonomy. Justice is distributing resources or care equally so that it's not just the rich people that can afford care, but it's everybody. Fidelity, which is kind of non-maleficence, so that's really maintaining loyalty and commitment, doing no wrong to a patient. So beneficence is the duty to promote good. So fidelity or non-maleficence is maintaining loyalty and commitment, doing no wrong. So making sure that whatever we do in our interventions is not going to harm the patient. And veracity is one's duty to always communicate truthfully. Mental health laws. So we do have laws, thank goodness, that are governing mental health, because way back in history, anybody could say, my wife is mentally ill, lock her up in a hospital, and she would be able to be locked up in a hospital with absolutely no proof, and it would just happen. So it's a good thing we have mental health laws, because hey, you could say, my nursing instructor for this mental health class, she really needs some help. I think she ought to be committed. And then somebody would come and take me to the hospital. So anyways, that truly is how things used to be. So we do have very strict laws now, and every state is different. So I'm just going to say that right off the bat, because the book kind of describes some very, basically general aspects that could almost be applied anywhere, but every state is different. I practiced for many years in New York State before I moved to Wisconsin, and the mental health laws there are similar, but there are some really big differences, such as we never had court hearings that were held on the unit. Matter of fact, we never had court hearings at all with our patients when they were admitted involuntarily. So there really are some big differences across the states. Anyways, so admission procedure: informal admission is sought by the patient, voluntary admission sought by the patient or guardian. So again, that doesn't really apply to Wisconsin. That actually applied to New York State and maybe some other states, but we just have something called a voluntary admission, and that could be sought by the patient or guardian. So don't worry about, I'm not going to be testing you about the names of the different types of admissions. Just more think about the concept of being able to sign yourself into the hospital and come in voluntarily. Or if you were, for some reason, if you were underage or if you had a legal guardian, a guardian could also admit you and make decisions for you on a mental health unit. Involuntary, and that's what we in Wisconsin call a Chapter 51, and that is without the patient's consent. So the patient doesn't necessarily want to be there. They probably don't recognize that they need some help. And you have to be mentally ill and a danger to themselves or somebody else, and or unable to acquire basic necessities of life. So such as the patient is not drinking any fluids, not eating anything at all, not taking medications. So it's not just, you can't just hospitalize somebody against their will because they're psychotic, because they have delusional ideas. So if somebody is calling maybe they're calling the White House and they're trying to give tips to the president because they know something about foreign affairs that the president doesn't know, and maybe it's really all very delusional. People have a right to make whatever phone calls they want. They can be calling news stations. They can be standing on a street corner talking about things that are delusional or hallucinating. And as long as they're not a danger to themselves or others, or somehow not meeting their own basic human needs, we can't put them in a mental hospital against their will. So that, again, that involuntary commitment, it is a temporary admission, and usually the person is admitted for 3 days, and then after that 3 days, excluding weekends and holidays, of course, at least that's how we do it in Wisconsin. So if they're admitted on a Friday of a holiday weekend, their court hearing may be delayed quite a bit, and they will be there more than 3 days before they actually get a court hearing. But anyways, they do have that court hearing usually within that 3-day period, again, excluding weekends and holidays. And then they may have another court hearing. If they are there for 2 weeks, they may have another court hearing at the end of that 2-week time period, and that they call their final hearing. So the first hearing is usually a probable cause hearing. So it's just what it sounds like. They're trying to figure out if there actually is reason, if there's probable cause that the person really did the things that people said they did, and if there's a valid reason for them to be in a mental hospital against their will. The one thing I just want to clarify on this slide, also, I just noticed the first bullet point kind of talks about, under emergency commitment, talks about the person who is confused or demented. And that is called a Chapter 55. But a Chapter 55 legally can no longer be admitted to a mental health unit. And that changed a few years ago. They used to be able to be admitted to a mental health unit, but now they can only go to a medical unit. So basically a Chapter 55 means that a person is not able to meet their basic needs. So usually you see somebody with Alzheimer's who is not eating or drinking again appropriately. Maybe they're incontinent and they're not even aware of it. They're not bathing. They're not taking care of their basic needs, certainly not taking their medication. But you can't Chapter 51 somebody because they have dementia. They would have to be a Chapter 55, and they cannot come to a mental health unit unless they have another diagnosis. So if they had Alzheimer's and they were suicidal, or if they had Alzheimer's and they also had bipolar disorder and they were in a manic phase or a depressed phase, then they could come to a mental hospital, but otherwise not. So okay, we talked about the court hearings, and then sometimes people have what we call kind of like assisted outpatient treatment. So they are court ordered to follow up with Health and Human Services, or they are court ordered, probably usually both, and court ordered to take medications. But not everyone who is court ordered to follow up with Health and Human Services is court ordered for meds. That's usually a separate court hearing. And don't worry about getting all, bent out of shape about learning all of the ins and outs of the legal system. Questions on the test would be pretty general in terms of legalities and patients' rights. And we'll talk more specifically about Wisconsin's laws when we get into clinical, because again, the book is covering kind of generalities that might occur across the United States. But we do have to think about that in many states there is court-ordered treatment that does occur for certain people, especially if they have come into the hospital repeatedly and if they are a danger to themselves and others and they do not have a history of complying to their medication. So it's really for to maintain theirs and everybody else's safety. So an audience response question: which individual may need involuntary hospitalization? A person with alcoholism who has been sober for 6 months but begins drinking again. An individual with schizophrenia who stops taking prescribed antipsychotic drugs. An individual with bipolar disorder, manic phase, who has not eaten in 4 days. Or someone who repeatedly phones a national TV broadcasting service with news tips. So I'm hoping as you're going through these four, again, it gets kind of sticky sometimes, but if you look at a person with alcoholism begins drinking again, we can't really put them into the hospital against their will for drinking. So that really is not the right answer. The person who with schizophrenia who stops taking their medications, we can't hospitalize somebody against their will just because they stop their medications. However, just as a side note, in the back of my mind, I'm thinking, well, if they stop their medications and they have schizophrenia, they may get to a point where they are not taking care of themselves and they are a danger to themselves or others. But at this point in time, no, we cannot involuntarily hospitalize A or B. C, an individual with bipolar who has not eaten in 4 days. Yes, definitely that person, because if you haven't eaten in 4 days, it's probably pretty likely that you're not drinking fluids either. So you are getting yourself into a compromised condition from a medical standpoint. Usually, too, if somebody is not eating, if they're bipolar, and I know we haven't done that learning plan yet, but if they're not eating, they're likely also not sleeping. And so they are getting to the point where they are a danger to themselves because they can have some severe medical consequences to their behaviors. And So D, again, somebody can be psychotic. You can be as delusional as the day is long, but if you are not a danger to yourself or others, then we cannot put you in the hospital or give you involuntary medications against your will. So, and that's actually a good change, because I do remember when I first started practicing in the early 80s, we could just give involuntary medications just about to anybody we wanted. So if somebody was psychotic, but they weren't being a problem on the unit, they weren't violent, they weren't a danger to themselves or others, they weren't self-harming, just because they were psychotic, we could actually give them an injection against their will if they refuse their medications. So it really is a good thing that these laws have progressed to the point where they really are protecting patients' rights. So due process in that involuntary commitment. So we have the writ of habeas corpus, which basically means that people have a right to be able to protest their being in the hospital against their will, that there has to be a valid reason, and that reason has to be shown in court. And that also there is at least restrictive alternative doctrine, so that means that the patient has a right to be treated in the least restrictive environment. So why would we have somebody in a long-term, large state mental hospital for a long time when perhaps they could just be really easily treated in an acute, short-term hospital setting for a few days and be stabilized quite well? Or why do we have somebody in the hospital at all if they aren't a danger to themselves or others and they really could be managed very well as an outpatient? So we want people to be served in that least restrictive environment as possible. There are legal aspects to discharge. So there's a conditional release, and in Wisconsin, we call that a settlement agreement. And you might see copies of the settlement agreement with some of the patients that you work with if you do have somebody that has gone through a court hearing. So basically, it's a list of conditions that they agree to in order to be discharged. So it's a legal document. The lawyer goes over it with them. The patient signs it, the lawyer signs it, the doctor signs it. And usually there are things on there that speak to the patient needing to take all their medications, stay away from drugs and alcohol, keep all of their appointments with their psychiatrist or with their counselor, refrain from any type of suicidal behavior or self-harm behavior. I think I said drugs and alcohol already. So it's basically those things: to keep themselves safe, to take their medication as ordered, not to use substances. And it's a legal document, and it's a binding document. So if that person who signed that settlement agreement and they go home, but say they miss their first doctor's appointment, they just don't show up to their psychiatrist appointment, the psychiatrist will pick up the phone, call the police, and the police will go back and bring that person back to the hospital. So that is how legally binding this document is, and this type of discharge is. So again, we call it a settlement agreement. An unconditional release is just a regular discharge. They're discharged, the doctor agrees that they're ready for discharge, they've got all their follow-up set up, and they're good to go. A release against medical advice, or an AMA, you probably might be familiar with that from medical units. People leave against medical advice from all different types of treatment settings, and usually they are released against medical advice if the person really could benefit from treatment a little bit longer. They're really not well yet, but the doctor will only release them AMA if they are safe. So they can't be acutely suicidal or homicidal. And if the doctor feels that they're acutely suicidal or homicidal and does not want to discharge them AMA, then the doctor actually has the right to have a medical director's hold placed upon the patient. So it's almost like they're voluntary perhaps, and they want to sign out AMA. Doctor thinks they're dangerous, get a medical director's hold on them, and it's almost like the doctor's putting them into like a Chapter 51 situation. So all of a sudden now the patient is involuntary. they're not there against their will. So then they have to have a court hearing. So that's an interesting thing that does happen from time to time, but that at least gives the doctor some leverage, because if the patient is insisting that they're going to leave, and the doctor really doesn't want to do that AMA because they're not safe, then the doctor has the ability to turn them into an involuntary patient. So it gets a little tricky sometimes. So maybe you'll see some different situations happen when you're on the clinical unit. So patients' rights under the law, patients have a right to treatment, and they have a right to refuse treatment. So just because they sign in voluntarily doesn't mean that they're going to accept everything that's offered. So maybe the doctor wants to do ECT thinking that's the best treatment for their depression, but they don't really want ECT. They don't have to have ECT. Or if they're involuntary, it doesn't mean that they cannot refuse treatment. So if somebody comes in, again, they're not voluntary, they're a Chapter 51, they're not there happily, they're there against their will, and the doctor prescribes medication for them, they absolutely have a right to refuse the medication. So you might think, if they're there against their will, then how come they can refuse? But they can. That is a basic human right. And if the only time that somebody will lose that right to refuse medication, especially, is if they are out of control. So if behaviorally they are out of control, they are a danger to themselves or to somebody else, then we can medicate somebody against their will, but otherwise we cannot do that. And so hiding medications in somebody's food or mixing it in pudding or ice cream or something like that would also be considered medicating somebody against their will, not just giving an injection. So they have a right to treatment and they have a right to refuse treatment. They have a right to informed consent. So if they were going to be getting ECT treatment, for example, for depression, they certainly need to know all the risks, the benefits, the alternatives, and they have to voluntarily accept that treatment, and it must be signed by the healthcare provider. Usually that's the physician. So nursing does not do informed consent for procedures. One thing we do consent for on the unit, however, is medication. So we have medication consents for it's a form, it's a piece of paper that the patient signs for every single psychotropic medication that they take. But that is not the same as informed consent. It falls under the realm of patient teaching. So the nurse does the patient teaching about the medication. The patient signs a form legally saying that yes, they agree to take this medication. All right, little case study. JS, a 27-year-old male, is court committed by his parents to your unit with a diagnosis of paranoid schizophrenia. He verbally lashes out at staff when they attempt to give him his medication. He states, "You are trying to poison me." The family of JS asks if you can force him to take his medications. How do you respond? So based on our previous discussion, he's not there voluntarily. So he's there against his will. Sounds like his parents perhaps had him chaptered. He's verbally lashing out. It doesn't say anything about violence. And it sounds like he's paranoid. He's saying, "You're trying to poison me." So no, we cannot force him to take his medication. So the family might be upset about that, but he has, at this point, if he's only verbally lashing out at staff, and not physically lashing out, we cannot force him to take his medications. So we would need to inform the family of that. So JS continues to argue with staff. He's not aggressive, but he's refusing all treatment. Legal and client's rights are suspended when a client is hospitalized involuntarily. True, false, depends on the state or depends on the physician assessment. So I'm hoping again that you said that is false. Their rights are not suspended. They're not stopped when a client is hospitalized involuntarily. If they're in the hospital against their will involuntarily, they still have all the same basic rights. They have patient's rights the same as any other patient. So their rights are not suspended just because they're hospitalized against their will. And it does not depend on the state. That is pretty much true everywhere, even though the states do differ a little bit. Okay, patients' rights under the law. They have rights regarding involuntary commitment and psychiatric advance directives, rights regarding restraint and seclusion, and right to confidentiality. So on page 97, your book is talking about, there's a nice little paragraph on rights regarding psychiatric advance directives. Personally, I have never really seen psychiatric advance directives put into play on the unit. And they're talking about if somebody, especially if somebody has chronic mental illness, that they are designating a preferred physician or therapist, appointing somebody to make mental health treatment decisions for them, preferring some medications maybe over others, consent or lack of consent for ECT, and people that shouldn't visit, preferred facilities or unacceptable facilities. I guess I really don't see any of that really documented, but I do know that the staff does a very careful history. I just don't know if it really is included. I don't think it's considered an advance directive, but in most of the charts, there is a lengthy interview that is done by the social worker, and they do outline the patient's preferences, even as far as like if the patient gets upset, what things make it better and what things make it worse. So they are given lots of opportunities to kind of give their preferences. So for example, a patient might say that when they're upset or they're feeling like cutting themselves, one thing that would be helpful for them would be if somebody were to talk softly to them and kindly versus somebody who might be more stern or more harsh with them. Maybe they prefer to be out on the unit, or sometimes they may be preferring to be by themselves in their room. They may prefer darkness or light. They may prefer somebody to not touch them or not, to really keep their distance from them when they're very upset. So I do see that type of thing put into motion, but I really don't see anything specific as far as advance directives. And as far as typical traditional advance directives, most of the patients that are on 1K are a full code. Very rarely is somebody not a full code, and that is usually an elderly patient that not only has mental illness, but they usually also have a very serious chronic medical condition such as cancer or perhaps emphysema, just something that's really chronic and life-threatening. So rules are rights regarding restraint and seclusion. So all patients have the right, again, to be treated not only in the least restrictive environment, but also using the least restrictive interventions that are going to be the most helpful for their safety. So we would never put somebody in a restraint or in seclusion, which is a locked room, without first trying multiple other interventions. PRN medications can be tried, different types of approaches. Again, they usually have the patient list, what types of things help them when they're under stress. So we would do everything possible to try to avoid that situation, because we really do want to treat people in the least restrictive manner as possible. So patients definitely have a right to know why they're going into seclusion, and sometimes it's a real difficult, tense situation. Perhaps a patient just loses control and they're lashing out at people. Well, it's kind of hard to explain at that point in time, but certainly after the person has calmed down, it's always helpful to kind of review the incident, kind of like debriefing, review and have the person talk about what went on and what maybe could have helped them differently, just giving them a chance to have some control. And again, the book kind of at the bottom of page 97 talks about orders, getting orders for seclusion or restraint and how many hours they're allowed to be restrained, but that also might differ from state to state. But you never ever can take a verbal order for restraint. You can't take PRN orders, like just restrain as needed. The restraint order usually at Sheboygan Memorial, I believe it's an hour that they have to get an order from the physician. So the patient needs to be assessed by the physician within an hour, and the doctor needs to come in and actually write the order. So, well, I guess they're writing it on the computer now, but again, the doctor needs to enter that order and actually physically see the patient. So we really have to make sure that we're not doing some of these types of interventions just because we're angry or we're upset or frustrated with the patient's behavior, that they truly are a danger to themselves or others, and that we're trying to keep them and everybody else around them protected, and nothing else seemed to work. So that also kind of leads into what the nurse needs to do as far as documentation. So again, on the bottom of page 97, they go over very nicely how thorough documentation should be. We should always be documenting very, very specific behaviors, put things in quotation marks as much as we can, and describe behaviors. We can't be vague and general when it comes to describing somebody's behaviors, the interventions that we tried, and then finally the ultimate behavior. Maybe the patient finally struck out at someone that ended up, needing to be having to call security and having that person put in either to restraints or seclusion. So it really needs to be documented very, very carefully and with just a great amount of detail. So the right to confidentiality. Well, everyone has a right to confidentiality. On 1K, they have an additional layer of confidentiality that I also will describe to you when you're in clinical. And that is basically, if the patient states that they are confidential, that means that they don't want anyone to know that they're in the hospital. So if somebody were to call and say, hey, I think I know so-and-so, I think they're there, the staff would say, I can neither confirm or deny that this person is in the hospital. And then they would just hang up. They would not, continue. They would not lead on at all that that person is in the hospital. If somebody tried to send flowers or a plant onto the unit for that person that's confidential, the staff would simply send it back. They wouldn't accept it. They wouldn't even let them drop it off at the nurse's station. Or if somebody tried to send them a card or a letter, we would have them have it sent back. We would not accept it because we can't let on in any way that the person is in the hospital, because they are deciding that they want to be confidential and they don't want anybody to know that they're in the hospital. Usually, most patients don't choose that route, but most of them do have a list of preferred people that they would like to visit or they would like to get phone calls from. So, audience response question. Eventually, JS agrees to electroconvulsive therapy, ECT. Which member of the team is responsible for obtaining the client's informed consent? So, obviously, that would be the physician. Patient confidentiality. So again, thinking about that. Legal considerations. So we have to think about HIPAA. I know that you know about HIPAA, so I'm not going to tell you any more about that than you already know. But we do have to think about confidentiality after death, because maybe that's something that we haven't quite run into yet. So if somebody passes away, it does not mean that we have liberty to talk openly about that person and their mental illness. So if somebody were to ask us, oh, I saw that person's obituary in the paper. I think they might have had mental health issues. Did you ever take care of them? What was wrong with them? We are not free to disclose that information. So we have to honor that confidentiality after death. We can't even talk to family members and tell them what happened to their person, or what, we can't tell them anything specific about their diagnosis, their thoughts, their feelings, anything like that. There is confidentiality even among professionals, professional communications. So patients have to sign a release form to have other people, other care providers talk to the staff on 1K. So usually the mental health counselor is the one that takes care of those things, but we can't just give information to other care providers. They can tell us things, but we can't share any information with other care providers unless the patient wants us to. So those are things that are very important. And then, of course, also if the person is working and they want a work release, like they want the doctor to write a letter saying they can go back to work, but usually the doctor would keep that pretty general, but the patient would also have to consent to that because then the employer would know that they were on a mental health unit. There are some exceptions to the rule, though, and these are things we really need to pay attention to, is that there is that duty to warn and protect third parties in the case of somebody being homicidal, and child and elder abuse reporting statutes. So the duty to warn means that if a patient on the unit, especially if they're preparing for discharge, they're saying that they are feeling like they're going to kill their boss, and they know exactly where their boss lives, and they really feel like if they run into them, they feel like they could shoot them, or they might even go find them at their house because they know where they live. If people are saying things like that, we have to call them and warn them. And yes, it is okay to do that. So that's really the only time. The duty to warn and the child and elder abuse situations. Those are the times that we absolutely, not only are we allowed to breach confidentiality, but we actually have to breach confidentiality. We are mandatory reporters in situations of child and elder abuse. So if we have an elderly patient on the unit and we believe that we have evidence that we think that they are being abused, or maybe the patient complains that they're being abused, or a child. When they had the child and adolescent unit, or the adolescent unit up and running, there were adolescents over there that would talk about being abused, and so they would have to call Child Protective Services. So in those cases, you absolutely have to breach confidentiality, and again, that duty to warn if somebody is. Usually it's a case of somebody threatening somebody's life, and yes, we absolutely have to warn that person, and then it's up to that person if they want to call the police and get an order of protection. We don't usually call the police in those situations, but we would call the person who is being threatened and say, hey, so-and-so is here in the hospital, they're on 1K, and they are threatening your life. So we really encourage people to contact the police themselves, and then hopefully they can get themselves some protection. So kind of interesting issues with confidentiality. Tort law. So you're thinking, okay, why are we talking about tort law, and what in the world does it have to do with nursing? Well, there are ways that nurses can actually violate a person's rights, and it may fall under the classification of tort law. So we're looking at assault, battery, false imprisonment, invasion of privacy, or defamation of character, which is slander or libel, so written or verbal. So yeah, nurses, depending on their behavior, if they're not behaving and intervening appropriately, can actually be charged with each of these. So assault is usually verbal. So if we actually threaten a patient and tell the patient that if they don't get away from the nurse's station, we're going to lock them up. Okay, that would be an example of assault, because we're not just telling the person the consequences of their behavior. We're actually threatening them, because truly they're not doing anything bad. They're not doing anything harmful. They're just up at the nurse's station. So if we say, get away from there, otherwise I'm going to lock you up in a seclusion room, that is assault. Battery is when we put hands on the patient. So I have seen this happen, unfortunately, in the past, where, again, the patient is really not doing anything harmful, but they're just in a place where the staff doesn't want them. They maybe are sitting on the floor, or maybe they're at the nurse's station constantly. And then they call security, and everybody puts hands on the patient to drag them away from the nurse's station. That is battery. So we have to be really careful about what we do, because that falls under tort law. We can't put hands on to somebody and drag them away from the nurse's station unless we have an absolutely valid reason to do so and can clearly document that that patient was a danger to themselves or others. False imprisonment. So if we're locking somebody in a seclusion room by themselves for really not a valid reason, or using restraints for not a valid reason, that can be considered false imprisonment. So, and the patient would have the right to sue us. Invasion of privacy. So if we are um, giving information that we shouldn't be to other healthcare providers, to family members, to visitors. So we might be violating HIPAA, but that is also a tort law of invasion of privacy. And then again, the defamation of character. So that would really have to do with what we say about a patient and what we write about the patient. So again, our documentation should always be very clear and objective, and not fall into that subjectivity of putting in our opinions and our thoughts and our feelings. Those really have no place in nursing documentation. So an unintentional tort is unintended, but it produces harm, and then we think about cases of negligence or malpractice. So again, things that nurses in all areas really need to think about. But with the other examples on the other slide, just mental health nurses in particular need to be alert to those tort laws. So standards, there are basic standards by which we are held accountable to, and those are our nurse practice acts, professional associations, organizational policies and procedures, so whatever policies and procedures they have at the hospital, and what is considered customary practice in your facility and in your state. So, and again, clear and thorough documentation. Your electronic health record is really it's a legal document. So just because we don't write in charts anymore, we certainly document things electronically now. It's pretty much the same thing that can be summoned in a court of law. So we really do have to be very careful that everything is very clear and thorough, because we don't want to implicate ourselves when it's not appropriate, and we certainly don't want to violate the patient's rights to privacy, confidentiality, slander, libel, all those things we have to think about. So I hope your head isn't spinning listening to all of this as far as all the legal implications, but it really, I think the legal and ethical aspect really has grown so much over the years, just because patients' rights in the past were so typically just completely disregarded. I mean, people in the olden days could get lobotomies whether they wanted them or not. They would just perform that brain surgery on people with no consent whatsoever, or giving people ECT treatments without any type of consent whatsoever. And I'm thinking about the movie One Flew Over the Cuckoo's Nest as being kind of a bad movie that really displayed a lot of the negative aspects of mental health nursing. And I think probably there was a lot of outrage, and people had very bad feelings, negative feelings against mental health, kind of based on that movie. So, anyways, just an interesting part of the day in the life, a day in the life of a mental health nurse. All of these things to be thinking about and considering. So, anyways, I think I've said enough about documentation. Obviously, that a record is very useful, basically, and it's only as useful as how complete that it is and how it really portrays the patient's behavioral status at the time it was written. So it's used for quality improvement, used as evidence again, and pretty much most places have electronic documentation. Maybe nursing homes are lagging behind a little bit, but violence in the psychiatric setting. Well, we could really have a whole learning plan just on this, and I really can't even touch on this topic adequately in the short amount of time for this learning plan. So maybe we'll talk about this in post-conference when you're in clinical. So somebody remind me and bring this up, because this really is a good topic. So employers are not typically responsible for employee injuries from violent patients. So again, that kind of comes from the authors of the textbook. That may or may not be accurate depending on what state you live in. I think all the states are actually pretty different, and facilities within states might be different as far as how much support that they give to a staff member when they're assaulted. And this is pretty much a hot topic now with, there was a mental health nurse that was actually killed by a patient not very long ago. Her name is escaping me at the moment, but a patient, I think it sounded like, kind of slammed her head down, and she was helping another nurse actually get away from this patient, and I think he slammed her head, and then there was something about her legs being caught or something in something, or I don't know, she had some injury to her legs also, ended up having a clot and died several days after the attack. So it is definitely a hot topic, and it really does evoke a lot of different thoughts and feelings that we have as healthcare providers. So basically, nurses really have to participate in setting policies that create and maintain a safe environment. We always have to document a patient's potential for violence and communicate our observations to our colleagues. They're really doing a nice job of this on 1K. They basically have a little huddle at the beginning of report, and sometimes they just give other types of news that's going on around Aurora. But then they have like a safety huddle, and they outline for every person that's sitting down listening to report which patients have had violent episodes in the past on the unit, or if they're having any current struggles with violent behavior on the unit. So we know, everybody knows what everyone's history is. It's very out in the open, which is a very important thing, because if you don't know somebody has a history of violence, then you may just be caught unaware. But if you know, you're going to be extra cautious and keep your guard up a little bit higher when you're working with that patient. So, and a potential for violence really could be lots of different things. I always tell the story about the patient who picked up an orange. They used to have like a bowl of fruit on the countertop in front of the nurse's station. And so a patient picked up an orange out of that bowl of fruit and threw it into the nurse's station at their doctor, because their doctor was not going to let them be discharged that day. So that is a history of violence. I mean, it sounds kind of funny. They picked up and hurled an orange at their doctor, but you know what? That got documented and passed on, that person threw an orange at their doctor, so that is considered an episode of violence, and each admission thereafter, that would always be brought up as this person has a potential to hurt other people. So very, very important things. It's a very important part of our role also as a mental health nurse in dealing with violent behavior. On a personal level, I think that if somebody is psychotic, I personally would not hold them responsible for their behavior. But I feel like if somebody is not psychotic and they are just angry about something, it is more likely, in my mind, I guess it's more likely that they should be held accountable for their actions. People should not be hurting health professionals. And mental health and the emergency room are probably the top two areas that are prone to patient violence. So it's not just part of the job. I think if we as nurses just sit back and say, oh, well, it's part of the job, then really nothing's going to change. So hopefully things will get better in that regard. So an audience response question. A nurse was the case manager for a client with serious mental illness for 6 years. The client died by suicide 1 week ago. Today, the client's spouse asks, I always wondered if my spouse was a victim of sexual abuse in childhood. What can you tell me about that? Can the nurse disclose information to the surviving spouse? So hopefully you say no, because we just talked about that a couple slides ago. So that is that confidentiality upon death. Chapter 7, the nursing process and standards of care. So I know that all of you are very well versed in CUSIN by now, since we have incorporated that into our clinical evaluation forms. So I'm just going to maybe just go through and give you a couple of examples that I have seen CUSIN play out very nicely on a mental health unit. So providing patient-centered care. So we have this patient who comes in from time to time, and he gets very manic and very delusional, and he gets kind of rigid. He likes things done his way. So he, at one admission, he has diabetes. Okay, so he has schizoaffective disorder. He has diabetes. He has high blood pressure, high cholesterol. I think that's it. Well, and schizoaffective disorder. So he's on quite a bit of medications, and some medical meds and some psychiatric meds, and diabetic meds, of course. So patient-centered care. He decided that he only wanted to take 2 pills at a time, every 2 hours. So, of course, his medications were not ordered like that. Okay, they were all ordered for like 8 o'clock in the morning, and his insulin was ordered. Well, we give insulin usually like right after they eat breakfast. So he would take his insulin, but he just really was insistent that he would only take 2 pills at a time, spaced every 2 hours apart. So it was really a challenge to do that because we had to problem solve and think about, okay, which medications are the most important that we want to give him first? Well, his anti-diabetic medication, yes, that was one of the high priority ones. But also his antipsychotic was very high priority. But on the other hand, darn it, his blood pressure was high too. So it really became a struggle. But we just problem solved the best that we could in terms of juggling his medical and mental illness issues and the medications that were prescribed. And we gave him his medications the way he wanted, 2 pills at a time, every 2 hours apart. Whew, so that was patient-centered care. It was difficult patient-centered care, but he was very happy that we were doing it that way. So it might not be such an extreme example, but really, truly, we have to take the patient's preferences into account. And so you're really going to find this quite a bit on the mental health unit. We may also have a patient who is seeing ghosts or something, or they're seeing things or having visual hallucinations, and maybe they don't want to take their medication right now, or they hand it back to you because they see a ghost in their cup. And so we have to try to find ways to work around that. So you may have to go back to the medication room and get another pill because they thought there was a ghost in the cup that that you gave them. So patient-centered care, really trying to make sure that we are focusing on their preferences and helping them to accept care. Working in multidisciplinary teams, again, I think I've already talked about how we work with many different members of the healthcare team and everybody works together really well. You have to have it that way because if one person makes an observation, say about a person's violence potential, and they don't tell anyone else, then it's very difficult to take care of that person, and a very untoward reaction might occur. Maybe that person will hurt themselves or hurt somebody else. Evidence-based practice. So it's a good thing we have evidence-based practice, and our interventions are based on theory rather than just based on, oh, let's see if this works, because I think that's what they did many years ago, like wrapping people up in cold, wet sheet packs or administering insulin to the point where they, you bottom out their blood pressure, you bottom out their blood sugar. So we do have the types of therapy and the types of treatments that we offer. Group therapy, they're all based in research. Applying quality improvement. There has been a huge amount of quality improvement on the unit, not only in the physical environment, but also in just different types of practices. So a really good example is a few years ago, they redesigned the 15-minute check sheet. It used to say just that the sheet wouldn't really say where you saw the person. It would just make you put a check mark by the different times every 15 minutes that you saw the patient, but you never had to say where you saw the patient. So a float nurse came down actually I think it was a float CNA from a medical floor, and actually documented that she saw the patient for a good hour and a half, 2 hours, when the patient was actually nowhere to be found and they were hiding on the unit. Yes, and so that wasn't a good thing. So it was just too easy to put a check mark in because she thought she saw this person, but honestly, being afloat, she perhaps didn't even know what that patient looked like. So there's danger when you have something that's such a vague system. So they improved that system, and now you have to, on the new check sheet, you have to actually put a check mark and also write where you actually saw the patient. So there's no fudging that you saw the patient. So that's a really good example of quality improvement. Certainly we use informatics to find out information about the patient and safety. Our biggest concern with safety, of course, is violence toward themselves and violence toward other people, so suicidal and homicidal ideation. And we have lots of interventions and things that we do and lots of assessments that we perform to make sure that everybody stays safe. And just other aspects of the safe milieu, not leaving a computer just sitting out in the hallway, just being very, very careful with what patients can and can't have access to. So standards of care, I'm going to go through this kind of quickly because truly you know what what the standards of nursing care are. And so I'm just going to highlight different things about assessments like for mental health. When you're assessing children, adolescents, and older adults, of course you have to take their developmental stage into account. And you have to put things in age appropriate terminology. And older adults too, you may have to repeat yourself often. You may have to explain things in simpler terms when you're doing your assessments. We have to always consider language barriers. We have to do a review of systems. So usually when somebody's admitted, they do a full medical workup. The nurse does a full head-to-toe physical assessment. It's just that they don't usually do that continuously like you would on a med-surg unit. They would only highlight the areas that that we do typically, which is pain, mental status, and integumentary. And then if any other area had a problem, that area would be continued to be assessed. But we don't usually do that full head to toe unless it's an admission. We'd always look at lab data. We're always doing a mental status exam. You'll get more familiar with that in clinical, and a psychosocial assessment. We want to know about their family members, their living situation, their thoughts, their feelings. So we really do delve into some very personal areas when we're talking to our patients. So we gather data. We want to do a spiritual, religious assessment, see if they have any values that we can help them support in the hospital. Do they need us to call the chaplain for them? Do a cultural and social assessment, and we always use those rating scales. We ask people to rate, again, their pain, their level of suicidal ideation, how strong it is, how strong the hallucinations are, their anxiety, their level of depression. So we really can ask people to rate almost anything, and that's a very helpful part of our assessment. So another little case study. As you begin the assessment process, Mr. R stops you and says, "I don't know why you need to do an assessment. I'm just here to get my medications adjusted." So how would you respond to Mr. R? What's the purpose of a psychiatric mental health nursing assessment? So I hope that you are thinking that if the nurse does a thorough, full assessment on admission, the nurse may pick up on something. He or she may pick up on a problem that the patient has that perhaps they're unaware of. So it really is helpful to do that full, thorough assessment. And sometimes there are physical problems that can actually present themselves as mental health issues, as depression or anxiety in particular. So it is really good for the nurse to look at all aspects of the patient's head to toe and their lab values. Standard 2, diagnosis. You know how to write diagnoses, right? Sometimes mental health diagnoses are a little bit more challenging to write than a medical one. But again, it's the same 3 components: the problem, the etiology, so that's the related to, and that's the cause of the problem, and then the supporting data is the signs and symptoms or the evidenced by. So we'll work on those a little bit more when we're in clinical, but for sure a little bit more challenging to write than medical diagnoses. And then, of course, we come up with our goals, and we really want that person to reach their maximum level of health and planning. So some things to consider when we're planning care: make sure that the care we're giving is safe, that it's compatible and appropriate, realistic, individualized, and of course, evidence-based. So we have to have the combination of clinical skill and the use of clinically relevant research in the delivery of effective patient-centered care. Implementation, so those are our interventions. And when we're going through the different learning plans talking about the specific mental illnesses, we're going to highlight different types of interventions and what we should do, what's helpful to do, what is evidence-based as far as our interventions with those different types of disorders. So basic interventions can be coordinating care, health teaching, health promotion, milieu therapy, pharmacological, biologic, and integrative therapies. Advanced practice interventions include prescriptive authority and treatment, psychotherapy, and consultation. Evaluation is always systematic, ongoing, and based on criteria. So we always want to evaluate just to make sure that our outcomes are met. And if they're not met, I guess we have to think about why not, and maybe the person is in denial. Maybe they need a little bit more help to understand. They need more teaching. All different types of things that we can do then to modify our interventions to try to help the person to meet their goal. So that's why documentation is very important, and it includes documentation of non-adherence. So if a person is refusing their medications, we really need to document why that's happening, and also the teaching that we're doing in terms of trying to encourage that person to accept their treatment. But again, not forcing, but just encouraging. So, all right, and we talked already about the medical record as a legal document. Chapter 8, Therapeutic Relationships. Okay, we are getting to the end of this very long learning plan that seems to be going on forever. So I know it's a little bit over an hour already, so I think I'm just going to keep going and finish this up. But this is really the best part of mental health nursing, is forming the therapeutic relationships, because there are some people that are so difficult to form a relationship with, and you just feel so positive when you are able to form a really good relationship with a difficult person and you actually see that you can make a difference in their life. So, concepts of the nurse-patient relationship. It's the basis of all psychiatric nursing treatment approaches. Yes, so it is really Hildegard Peplau. Remember Hildegard when I talked about her a while back? She truly is my hero. She's the mother of mental health nursing, and this is really where she was, where she put all of her effort into her theories and her practice. So that nurse-patient relationship is truly the basis of what we do, and by our relationship, we are establishing that we are safe, confidential, reliable, and consistent, and that we have a relationship with clear boundaries. I just want to say something about the confidential part, though, because sometimes patients think that they can tell us something and we won't tell anybody else. And usually if a patient says, I want to tell you something, but don't tell anyone else, I would stop them and say, I have to tell the rest of the treatment team if it's something that's really appropriate to your care. So to give them the choice if they want to continue to tell you, or they don't want to tell you now because you're saying that you can't keep that secret. So we really do have to make sure that we don't ever tell a patient that, yes, we're going to go ahead and tell me because I'm going to keep your secret, because maybe it's something that's very significant as far as their plan of care or their safety, and we really can't keep their secret. So, but we want to make sure that the patient knows that we're safe, that they can tell us anything, and that we're not going to respond by being judgmental. We're going to be reliable. We're going to do what we say we're going to do. If we say, I'll be back in a half hour, we're going to be back in a half hour. If we say, I'm going to stop in before I go home for the day and check in how you're doing, you stop in at the end of the day and check in before you go home. So just that reliability, being consistent. Consistent staffing is very helpful too. So sometimes in report, it's interesting that we'll be sitting there, and sometimes the staff are kind of going back and forth, and they're not arguing, but they're just basically kind of negotiating with each other sometimes to trade assignments, because somebody will say, well, how come I didn't get that person? I admitted them and I worked with them yesterday, and how come I don't have them today? And so somebody else will say, well, I've got them, and then they kind of go back and forth, and most of the time they will end up trading so that that person gets the patient that they admitted and they had the day before, so the patient has some level of consistency. So it really is hard when they're making out their assignments, because they want that consistency, but they also have to balance the acuity. So if somebody has all of the patients that are manic, or all of the patients that are hallucinating and refusing their medications, it's not a very well balanced assignment. And so somebody might end up having a really bad day and everyone else is having an easy day. So it's definitely something that needs negotiation. The relationship has to have clear boundaries. The patient needs to know that you are the nurse and that you are not their friend, and that you are not going to be um, having your own needs met through their communication with you. You're not friends. You're not sharing and dumping your problems onto them. They are free from that. So that's actually a very important part of our setting boundaries with them. So, therapeutic use of self, that's what a mental health nurse does. We use our personality consciously and in full awareness. Now, we all have different personalities. So, some of you might just be really happy, cheerful, always smiling, really outgoing, vivacious. Maybe some of you tend to be more on the loud side, really gregarious and loud and friendly, and some other people might be a little bit more shy or quiet. And there might be, every other different type of personality in between. So it doesn't mean you have to take on a fake personality and be something that you're not, but you may have to modify your personality a little bit depending on the patient and the situation. So if you are a very quiet, shy person and you're working with somebody who has depression, you might have to just kind of step it up a little bit. And not that you're going to be overly cheerful, but you may have to be maybe a little bit more assertive than you normally are because the patient is so depressed and they kind of need that from you. Or if somebody is manic and you are a very, very vivacious, cheerful, talk fast, loud, kind of friendly person, and the person is manic, you might have to tone yourself down a little bit. And again, we'll kind of talk about this again in clinical, but it does get interesting sometimes. But you might have to just modify yourself a little bit so that you're not overpowering the patient and getting them all accelerated. So we're using our personality. We are trying to establish relatedness. So we're trying to relate to the patient. And again, that doesn't mean sharing your own personal feelings. We really don't share personal issues with the patient. We don't want to burden them with our problems, but we do want to establish a relationship with them and try to get them to talk to us. And we want to structure our nursing interventions so that we are trying to be helpful to the patient and make sure it's patient-centered. It's what the patient is really looking for. We want to facilitate communication of distressing thoughts and feelings. So that can be a very difficult thing too, because if you're not used to listening to people's really deep, dark secrets and really difficult things, it might be hard for you when you're in clinical to listen to people talking about how difficult their life is, how sad they are, how they'd like to be dead, how they'd like to commit suicide. That might be really tough for you. So, well, in clinical, we'll practice that a little bit with each other before we actually head out onto the unit. But that can be very difficult to listen to somebody's really difficult feelings. So that definitely can be a challenge. We assist patients with problem solving. So we don't tell them what to do, but we might do some teaching and offer some suggestions. Have you ever looked into exercise? Have you ever looked into yoga? But we're not going to tell them what to do, but we may have to help them a little bit or coach them with problem solving. It's really great if we can help the patient to come up with their own solutions for their problems. So it is not our job to come up with a solution for their life difficulties. We want to try to help the patient examine their self-defeating behaviors and test alternatives. So we might even help the patient by role playing. So if they have difficulty with assertive communication, maybe you can do a role play and say, okay, I'll play the boss and you play yourself and you try to ask me for a raise because that's what you're working on. That's what you're really, afraid to do. So it's just kind of using some of those when we talked about the theories, just some of the like Ellis's rational emotive theory, and it's just using some of those, cognitive behavior therapy, helping them examine their thoughts and feelings. So you're not really doing therapy, but you're just using some of those techniques in your therapeutic communication. So And we always want to promote self-care and independence. And again, that might be something difficult for you too to adjust to, because you don't just jump in and pass trays in the morning. You don't just jump in and wash your patient up. We want them to get up out of bed, go to the dining room, and get their own breakfast tray and eat in the dining room, hopefully. Or if they don't want to eat in the dining room, bring their own tray back to their room if they're capable and able to do that. We want them to gather up their own laundry, put it in a bag so that we can wash it for them, and then we can give it back to them and they can fold it themselves. We encourage them, they can make their own bed. We don't need to be going through and making everybody's bed. The only time we would make a bed or help somebody is if truly they are too psychotic or if they're physically sick that they simply are unable to do those. But we really want to help them to mimic as much of their own like home type behaviors as possible when they're in the hospital. Social relationships are initiated for the purpose of friendship, socializing, enjoyment, or accomplishing a task. So what I really want to point out is that what we're doing in mental health nursing is not a social relationship. There's a big difference between social and therapeutic relationships. So in a social relationship, mutual needs are met. Communication is to give advice, to give or ask for help. So it's a mutual back and forth. And the content of communication might be more superficial in a social relationship. However, that's not always true. There are friends where friendships where people really can share lots of really deep personal things and maybe even secrets. So it doesn't always have to be superficial. But a social relationship is just very, very different. The main thing is that it's not a mutual give and take. It's not the patient tells me all about them. Now I'm going to tell the patient all of my personal thoughts and feelings. We really do try not to share anything personal about ourselves because it takes the focus off of where it should be, which is the patient. So a therapeutic relationship, the needs of the patient are identified and explored. Clear boundaries are established. So you're not going to be seeing them and meeting them for coffee after they're discharged. That's the end. This is the end of your relationship when they are discharged from the hospital. There might be times where if you live in the same community as your patient, that you might run into them somewhere. And that's very likely to happen. But I would highly suggest that if that does happen, that you just go about your business and do not go out of your way to say hello to somebody. Most of the time, the patient, maybe in the hospital, they really liked you, they loved working with you, but when they see you out in the community and they're not in the hospital anymore, sometimes seeing you can just bring back bad memories of, oh my gosh, I was so sick back then, I was in the hospital. And it's not that they're blaming you or upset with you, but you just might be a reminder of a difficult time in their life. And they may actually just shun you and not even look at you or walk the other way. And I would just totally accept that. I would not go out of my way to try to say, hey, didn't I take care of you? We just wouldn't really be doing something like that at all. So clear boundaries, no communication after discharge. If somebody came up to me in Walmart or someplace and said, hey, do I know you from somewhere? Most of the time I would probably say, oh, I don't know. I teach at LTC, so probably not. And just, just leave it at that. And most of the time people are satisfied with that. But anyways, problem-solving approaches are taken, new coping skills are developed, and behavioral change is encouraged. So that's the main part of how we work with people in the context of our therapeutic relationship. So the nurse has to be accountable, do what we say what we do, focus on the patient's needs, not our own needs, have clinical competence, understanding their not only the patient but their diagnosis, their medication. So that clinical competence, understanding and knowing therapeutic communication, which, by the way, there is a handout in Learning Plan 1 that's called Therapeutic Communication Techniques, and I also have that same handout in the clinical, in the intermediate clinical. And I know it's 18 pages long. It is quite long. I might think about doing a recording sometime this summer, just maybe that will make it more interesting than just reading it. But it is something that's really, really important in this course and also in clinical. I will never ask you a test question that is going to ask you to name what the technique is called, but I will ask you to differentiate in a test question between what response would be therapeutic and what response would be non-therapeutic. So it really is important to look over those, not with the purpose of, I know 18 pages is a lot, not for the purpose of memorizing the name of the technique, but simply to be able to look through and differentiate what's therapeutic and what's not therapeutic. So I just wanted to put in a little plug for that 18 pages therapeutic communication document. So anyways, that's part of our clinical competence, is using those techniques. We want to delay judgment, so we don't want to judge people, and we certainly don't want to convey negative feelings toward the patient, no matter what their behavior has been. And that, again, can be very, very difficult. We had a patient that had homicidal ideation towards his infant granddaughter. So you think, wow, how can anybody feel that way? But you can't therapeutically work with somebody if you are having angry feelings and judging them. So that's where the next behavior is the supervision. And if we have a patient that's really difficult for us to deal with in a therapeutic manner, we may need some clinical supervision. So we may need to go to our supervisor or one of the doctors on the unit or a social worker to kind of talk about our feelings and talk about how we could work with that patient more effectively without being so judgmental. If there is a type of person that's on the unit that you just can't get past something they did, maybe it's, gosh, we had a patient once that was, I believe it was a young male patient that was molesting teenage girls. And I had a male student at that time who just absolutely could not work with that person because he himself had teenage daughters, so he was just too close to that situation. And then it's always a good idea to say that, and then we can always change the assignment so that you don't have to work with that person if you really don't think you can kind of get past your feelings and work with them effectively. But it's very hard sometimes not to be judgmental because of patients, especially when they abuse or neglect children. So we really do need, that's where supervision comes in. And that's where we really grow with our nursing skills and our communication, is when we get that supervision and get a different perspective and talk about why it's so difficult for us to work with that person. So very necessary behaviors for nurses. So we have to establish boundaries. Boundaries are super, super important in mental health nursing, maybe more so in other areas of nursing. I don't know. When I was in Rochester, New York, and I was practicing there, I was on a policy and procedure committee. And we on the mental health unit, actually we had 4 floors of mental health units, but we had a policy basically that said that we do not socialize with our patients after discharge. And some of the other nurses on the committee were shocked, and they couldn't believe that we had a policy like that. And they even wondered why. They questioned, why do we even have a policy like that? Because one of the nurses said she worked in rehab and said, well, gosh, lots of times we marry our patients. So they take care of young men who are paraplegic or quadriplegic, and they fall in love and they end up getting married to their patients. And so she thought it was just a normal thing, that why don't we do the same thing? So that was kind of an interesting committee to be on. But we have boundaries really for a reason. We really want the patient to be able to learn the skills to have good relationships in the outside world. And we do not want, because we're in we're not on a level playing field, unfortunately. They see the staff, the nurses, the doctors, any of the staff members, they see us as on a higher level from them. Okay, so they see us as having some authority over them. We're authority figures. And so if we were to develop a relationship with them, that would constantly keep them in that dependent position. So we really don't want that. We don't want to keep them in that. And I'm not saying that I feel like we are authorities and we are in a higher level than they are, because I don't feel that way, but that's how they feel. And you're going to see that when you are on the unit and you notice that the patients talk to each other very differently than they talk to you, because you're a staff member now. Now, even if you're a student, you're a staff member. They talk so differently to us than they do to each other, because they don't feel that we're on the same like level playing field. So we don't want to burden somebody with having them stay in that dependent position. We want them to get out there and to be able to develop good relationships, good healthy relationships with other people in their community. So we have lots of boundaries that we need to establish. So physical boundaries also includes touch. We do not touch patients on the unit. So that may sound kind of mean, maybe a little bit, or a little standoffish. So if somebody's crying, we don't put our arm around them, we don't hold their hand, we don't touch their arm, mainly because many patients have had a history of abuse, and therefore they really don't like that aspect of care. They don't like touch because touch might remind them of somebody that was abusive towards them. It may really trigger a bad response in them. So we don't touch people. Sometimes we have to touch them a little bit. If they're falling out of bed, of course we have to touch them. We have to grab them and pull them up back onto the bed or something like that. To take their blood pressure, of course we have to touch them a little bit. But what we're talking about is really like giving back rubs, or like I said, hugging, putting your arm around somebody, holding their hand. It's that type of touch that we don't do. The unit even takes it as far as not like helping to do somebody's hair. Like we wouldn't be braiding somebody's hair, because that would be too much touch and that would be against the hospital policy. So physical boundaries. And we also expect the physical boundary to be respected by the patient, that they're not going to be hugging us, touching us, and they should also be not hurting us either. They shouldn't be hitting, kicking, punching, any of those types of things too. So there's lots of aspects of physical boundaries. We make a contract usually for working with somebody. So usually when you introduce yourself, you say, I'm so-and-so, I'm going to be your student nurse today. The nursing staff would be, I'm your admitting nurse and I'll be working with you whenever I'm on duty, or try to work with you whenever I'm on duty. So you kind of make like a contract saying, I'm going to be working with you, spending time with you, helping you, listening to you talk about your problems. So that's all part of the boundaries. It's like establishing what your role is, why you're there, and why you're talking to them about things that are so very personal. Personal space, is different for different people. When somebody is manic or if they have schizophrenia, I can't talk anymore. So if they're in a state of mania, or if they have the disease of schizophrenia, many times those two conditions, people really have a lost sense of personal space. They may come right up to you and actually even brush your arm or your leg while you're standing in the hallway, because they don't have a sense of personal space. So we do try to point that out to patients if we can, and just step back and make sure that we take our, it's okay to step back and take our personal space. But that's something we try to encourage patients to respect, and we also have to respect their personal space. So boundaries get blurred when the relationship slips into a social context. So a long time ago, I had a student say that she was going to attend a patient's party. This patient was in a manic state, and she said she was going to throw a big party in the summer, and the student was invited, and the student was just going along with it, saying, yep, I'm going to come. And so that was not the right thing to do, because we don't let our relationship slip into the social context. The only kind of exception to that is that doesn't mean that you can't ever talk about anything that's like superficial or social. Sometimes if a patient really has a hard time talking, it's okay to start asking them about their hobbies, or do they like watching the Packers, or do they like baseball, maybe cooking, get them maybe talking about another topic like that. Or if you notice they have an accent and they're from somewhere down south and you come from down south, you can maybe talk about that a little bit. And then all of a sudden you've got a connection, and now they're all more willing all of a sudden to maybe disclose and talk to you about their problems and feelings. So sometimes just talking about things that are maybe more social or superficial, at least briefly, can maybe help you connect with somebody. So it's not that you can never talk about the Packers or never talk about gardening or something like that, but you just don't want that to be all of the conversation that you have with your patient. You do want to try to eventually help them to talk about their thoughts and feelings about what brought them to the hospital and what types of things that they want to change so they can live more happily in the outside world. So we never want to see boundaries blur to the point where the nurse's needs are met at the expense of the patient's needs. Real extreme example of that would be I worked with a psychiatrist that worked with young women that had eating disorders, and this man was in his 50s and he was already divorced like 3 times, married and divorced 3 times, and he developed a personal relationship with this female patient, and she went to live with him after she was discharged. So of course that is a huge boundary violation, and actually I believe the psychiatrist lost his license to practice. So that's but again, that doesn't happen often, but there are people that do develop personal social relationships with patients, and usually it doesn't end well as far as their careers are going. So blurring of roles. So transference and countertransference. I think I mentioned way back in the beginning. So when we were talking about Freud, this is one of those concepts that we actually still think about and use. So now I'm going to explain these a little bit. So transference is the patient unconsciously and inappropriately displaces onto the nurse feelings and behaviors related to significant figures in the patient's past. And transference intensifies in relationships of authority. So again, it's not that we want to be in authority over patients, but they really do feel that way. We're the ones treating them. They are the patient. We are the caregiver. So that kind of does set it up as that we are authority figures. So the patient is basically treating you as if you were somebody from their past. And many times it could be a negative thing. It could be a positive transference, but more often than not, I've seen negative transference reactions. So the patient is they're just not dealing with you very well at all. They don't like you. They talk negatively to you. They are rude. They're abrupt. They don't want anything to do with you, even perhaps. And that's probably because maybe you remind them of their mother or a very difficult friend that they had in their life. So that's what transference is. Countertransference is the nurse displaces their feelings related to people in the nurse's past onto the patient. So maybe the patient reminds them of somebody in their past that they had, again, maybe had a difficult relationship with. And all of a sudden the nurse is finding themselves like snapping at the patient or setting limits in a way that's not really appropriate, that's maybe just a little bit more harsh, or they're maybe a little bit more judgmental. But the nurse should really recognize when countertransference is happening. So if you're all of a sudden reacting to somebody in a really kind of negative way and they just ruffle your feathers and you're just kind of annoyed with them, it's always good for the nurse to think, why am I feeling like this? What in the world is going on? And that's again where the nurse could use some supervision and be able to talk to somebody about how they're feeling. So, and many times it goes kind of back and forth. If the patient is having a transference onto the nurse, then many times the nurse has a countertransference back onto that patient. So sometimes the countertransference manifests itself in the nurse over-identifies with the patient. So that might be more of a positive countertransference reaction. So I'll give you an example. So the nurse is taking care of a patient, and the patient really reminds her of her sister that died, and she just loved her sister to pieces. Her sister was a wonderful person. So now the nurse is just feeling like she's just over-identifying with this patient. She reminds her of her sister, and she might be like bending rules for that patient, might be giving them some extra privileges that nobody else has, or just kind of treating them differently, talking to them differently. So that could be that over-identifying with the patient. I have an interesting example too. If I ever have a patient that reminds me of my second grade teacher, I know for sure I'm going to have a countertransference reaction. So I had a really strict, mean second grade teacher. And, we had those desks way back in the day that the top lifted up. And so if your desk was a bit messy and you had too much stuff in there, your desk didn't kind of close all the way down. So my desk was like that. The lid was up a little bit, maybe sticking up a half inch or an inch. So clearly it was kind of a mess in there. So the teacher noticed that, and so she had me stand up, and she took my desk and she dumped it, and everything that was in my desk just went all over the floor. And I was in second grade, so I was probably 8 years old. And then she had another student that was her teacher's pet, so she made her stay after school with me and clean my desk out. And she wanted this girl to show me how to organize my desk. And so that was really kind of embarrassing. And then this teacher drove me home, and of course then had to talk to my mother in the driveway. So that was just like a horrible childhood experience. So if I ever take care of somebody that would remind me of her, I know that I would have a countertransference reaction, and I would probably have a difficult time being therapeutic. So anyways, enough about transference and countertransference, but it's just another way that sometimes roles get a little bit blurred. So values, beliefs, and self-awareness. So the nurse has we each have our own values and beliefs, and they're just different. Everybody has different values and beliefs depending on your own family, your upbringing, your culture, your religious values, your family values. So, and that's okay. We just need to recognize and know what our beliefs and our values are. And so we do choose our beliefs and values from a variety of influences and role models in our life. And they do come into play when we work with patients. So back to Hildegard Peplau. So her model of the nurse-patient relationship, again, is the most important aspect of a psychiatric nurse. So the orientation phase, the working phase, and the termination phase. I will have a couple of test questions on the what goes on during those 3 phases, because those are really pretty important. So the orientation phase is when you're first establishing a rapport with the patient. You talk about the parameters of the relationship, that it's only in the hospital. You might have a formal or an informal contract as far as how often you're going to meet and talk about issues. You're going to explain confidentiality, and of course the fact that you can't keep confidential anything that needs to be shared with the rest of the treatment team. And during the orientation phase, you do talk about termination, that eventually when the patient is discharged, your relationship will come to an end. So it's always good to let them know that right in the very beginning in the orientation phase. The working phase is when you're maintaining that relationship, you're gathering more data, you're trying to help them with problem solving, self-esteem, facilitating behavior change, overcoming resistance, redefining goals, and it's really when you're trying to get that person to have alternative behaviors that are a lot more healthy and adaptive. So that's a really satisfying stage to be working with. The patient trusts you and you have a good rapport going, and now you can actually do some work. The termination phase, then you summarize the goals and objectives achieved. You discuss ways for the patient to incorporate those new strategies into their daily life. You might review the situations of your relationship with them. You can say that you enjoyed working with them, and you might even exchange some memories about what it was like to work together during their hospitalization. So factors that help that nurse-patient relationship, certainly consistency, having the same assignment is very helpful as much as possible. Pacing, take it at the patient's pace. Sometimes you might be gung-ho that, oh boy, I'm starting my mental health clinical and I'm going to sit down and this person's going to open up and they're going to tell me everything. Well, maybe they don't want to because it's the first day they're working with you and they don't know you yet. They don't know if they can trust you. So take it at their pace. Let them set the pace. And sometimes you might be, as a student, kind of frustrated with that because, again, you just want to dig right in there and just kind of help them as much as you can, but they might be a little standoffish. I see this all the time. Usually, day 2 goes much better than day 1. And when we used to do clinical for 3 days a week, day 3 used to be fantastic. But anyways, so active listening to the patient, and that really means listening without trying to think of what you want to say next while the patient's talking. And that's so tempting, because therapeutic communication is something that you're going to struggle with a little bit. You're going to feel awkward. You're not going to know what to say. You're going to be trying to think of what's the right thing to say versus what's the wrong thing to say. And that's going to hamper your conversation. So sometimes it's better just to relax and focus on the patient and actually listen to what they're telling you and what their experience is, rather than trying to put it through the filter of your own experiences or what you're going to try to think of to say next. Sometimes we have initial impressions of the patient. Sometimes we have to kind of suspend judgment and not necessarily let that influence us. We have to promote patient comfort, but also and balance control. We want the patient to have some control, but we certainly don't want them out of control and making decisions that are not appropriate. Patient factors include trust and active participation. So the nurse has a lot to do with the whole developing the therapeutic relationship. But if the patient doesn't trust you, if they're not able to develop trust and they don't actively participate, it's really difficult to have that nice nurse-patient relationship, working relationship going. So we do sometimes, we do have to rely on the patient to cooperate and to be able to participate with us. So factors that promote growth, and these are things that the nurse, again, needs to do. So the nurse needs to be genuine. So again, I talked about we all have different personalities. Some of us are quiet. Some of us are more outgoing and social and verbal. So however you are, you have to be your own genuine self. Therapeutic communication doesn't mean that you're a robot and you're just saying these things like off a sheet of paper and you're reading these and you're not really genuinely being yourself. Patients can tell if you are not genuine and if you're not being yourself. Empathy, not sympathy. So I didn't talk yet about all of the videos that are in the Learning Plan 1. Most of them really are quite short. There is an empathy video there. Absolutely, you should watch that one. It's only about 3 minutes. It's just outstanding in terms of helping you to understand walking with the patient in their shoes, and that's basically what empathy is. So definitely watch, all the videos are really quite useful, but that's a really good one, and I'll show that one to you again in clinical. Giving somebody positive regard through our attitudes and our actions, that can also be very difficult. So you have a person perhaps who's been drinking steadily, and they're quite intoxicated. They're at a 0.35. They come onto the unit and maybe they have urinated on themselves. They smell. They haven't showered or bathed or anything in days, and so they have a very strong odor. Perhaps their behavior. They're still intoxicated. Perhaps their behavior is just a little bit difficult. They're yelling at you. They're swearing. It's kind of difficult to have positive regard towards somebody like that. But patients really do pick up on if we don't give them positive regard. So we need to treat that person that is the most difficult to give positive regard as a person who is worthy of our attention and our care. And that's really basically what giving positive regard is, no matter what. So another example would be that we had a patient on the floor who had actually had a medical procedure and had a colostomy bag. And he was very upset that when he was on the medical floor, the nurses were apparently, when the nurses came in to change that colostomy bag, that they were like reacting to the smell. Like he could tell by their facial expression or whatever that they didn't like the smell. And that made him feel even worse about having his colostomy. And actually, part of the reason he came to us is depression related to having the colostomy bag put in, and also that he just was not interested in self-care at all. So he came down to be treated for depression. So we made sure that part of his care plan said that when you walk into that room, no matter how it smells, put a smile on your face and do not react to the smell, because that was so distressing to the patient. So we were giving him positive regard and treating him as a valuable human being, even though perhaps the room did smell a little bit. So again, we do that by our attitudes and our actions when we take care of people. And you know that old saying, actions speak louder than words. So that's something important to consider when we're giving positive regard. So attending, so really making sure that we're fully present and listening to the patient, that we aren't standing at the doorway trying to talk to them. We actually go in the room and sit down or stand up if there's no chair in the room, that we're actually spending time with them, that we're not just in the doorway saying, hey, you doing okay? And you're just like expecting them to say, oh yeah, I'm fine. So really paying attention to them. Again, suspending value and helping the patients develop resources, both internal and external resources. So now the last chapter is therapeutic communication. So again, my favorite topic, the relationship and the communication. So factors that affect communication. So personal factors, environmental, and relationship factors. So on page 140 in Varkarolis, there's a chapter, or a page, excuse me, a paragraph. Oh, I can't think straight at this late at night. But anyways, there's a nice paragraph about the personal factors, environmental, and relationship factors. So I'll just highlight a little bit of that. So personal factors that might make it difficult for a patient to communicate would be, the first thing I would think of would be if the patient would be psychotic. So they may really have trouble expressing their thoughts and feelings in a way that we can understand. Or if somebody is really manic, they sometimes talk so rapidly and they jump from topic to topic, and it can be very difficult to even follow their train of thought. So there might be some of those types of barriers. There might be language barriers, or even cognitive barriers that people have that might make it difficult with communication. One of the biggest things that you can do as a nurse to try to understand people when they're having trouble communicating is, instead of trying to listen to the words and the sentences and trying to make them logical when they're not, would be to try to pick up on a theme or a feeling that's behind what they're saying. And that's actually a very helpful thing for the nurse. So if you pick up on sadness, depression, loss, fear, some kind of a feeling state, that's actually better. And then you can respond to that and say something like, it sounds like you're feeling afraid, or it sounds like you're feeling sad, even if you can't make heads or tails sense out of the words that they're saying. Environmental factors. Certainly, we might think of like a nice, calm, quiet area is the best as far as talking to somebody, and usually it is, but honestly, we don't usually close the door when we're having a conversation with a patient just for safety reasons. It's always better to kind of be seen and to not ever let yourself get backed into a corner. Of course, we would never want to be near the window and have the patient be near the door. That's another environmental factor that's just for your safety, and that's something I'm also going to reinforce to you when you're in clinical. But it is sometimes, if you're having a difficult topic, communication on a difficult topic. Like if you're talking to somebody about their suicide attempt, or they recently found out that they were pregnant and they're not happy about it, or something like that. You don't want to have that type of conversation in the middle of the lounge when all the other patients are sitting around watching television or something. You want to get that person in a private setting. And students usually ask me too, is it okay if I contract for safety with the patient in the dining room? And I'll be like, no, wait till you get them alone. So, there are different factors in the environment that can impact your communication. And again, I talked already kind of about the inequality of the relationship, that we are really seen as authority figures, and so sometimes that can really impact the way that we communicate with a patient, or the patient is their either willingness or unwillingness to communicate to us. So verbal obviously is the words that we speak. It communicates beliefs and values. I'm thinking about us and the patient. Perceptions and meaning. It can convey interest and understanding, insult and judgment, clear or conflicting messages, honest or distorted feelings. So verbal is kind of obvious. Nonverbal is our tone of voice, our emphasis on certain words, physical appearance, facial expressions, body posture, amount of eye contact, and hand gestures. So again, some of those might be culturally determined, but if we think of ourselves as a nurse, and if we are having a loud or harsh or shrill tone of voice, or really if we're speaking really quickly, if our physical appearance, if we have our hands on our hips or our hands are crossed, our arms are crossed in front of us, that might look a little bit threatening. Or actually, even if your hands are behind your back, the patient might be really suspicious as to, oh, what have you got back there that your hands are behind your back? Does he or she have a shot for me? They might be really worried about what's going on back there. So we really do have to watch our everything, our facial expressions, our body posture, and again, eye contact. Eye contact for some cultures might be something that they don't accept very much. They either have very little. There are some cultures that have very little eye contact, or they would consider our usual Western eye contact threatening to them. So we have to be very careful about that. But of course, also staring eye contact is not considered therapeutic either on our part. And our hand gestures, we have to be very careful about every aspect of our physical being when we're communicating with patients. Sometimes there can be discrepancies between our verbal and nonverbal, so messages can appear to be one thing when in fact they're another, and people are often less aware of their nonverbal messages and behaviors. So the verbal message can be called the content, and the nonverbal behavior is the process. So therapeutic communication techniques, again, refer to that handout. I know it's 18 pages long, but it really is a good handout. I like it even better than they do have a table in Chapter 9. Let's see, starts on page 143 and goes to page 144, but I really like the handout even though it's long, because it does give you some really good examples and a really thorough, great rationale for why to use the technique or why not to use the non-therapeutic techniques. So we consider these communication techniques to be tools for enhancing communication, like using silence, active listening. There are some clarifying techniques, and honestly, I don't really care that you know the names of the techniques, as long as you can pick out the therapeutic technique, what the nurse should say versus what the nurse shouldn't say in a test question. That to me is the most important thing. I do want to mention though quick about open-ended and close-ended questions, because there are times when we have to use open-ended questions, and there are times that we have to use close-ended questions. So we think, oh, we should always be using open-ended, but actually if we want to encourage somebody who is capable of expressing their thoughts and feelings coherently, yes, open-ended questions are great. But if somebody is psychotic or manic, their thoughts are all over the place, it is not helpful to ask them open-ended questions. And, well, try it sometime. And if you have a patient that their thought processes are really disorganized, yeah, you'll be there for quite a while they're trying to answer your open-ended question. So Close-ended questions can sometimes just give you the information that you're looking for in a very, quick way. Sometimes you might need to ask close-ended questions on admission or in an emergency situation, or if somebody's thoughts are so disorganized that you need an answer from them, but you can't get it by asking an open-ended question, then it's time to be a little bit more directive. So just to touch on some non-therapeutic techniques, but again, I refer you to that handout. Excessive questioning, so that's really called probing. So you're asking them all kinds of details about things that you don't really need to know. I just remember reading a process recording a long time ago of a student that was talking to a patient who was a clergy person and asking them, like, what church are you the clergy for, and how many people are in your church, and where is the church located? Things like that are really extraneous detail. You don't need to know that. That isn't important to why that person is on the unit and why they had a suicide attempt or were depressed or whatever. So excessive questioning, we really have to think about why we're asking that question and make sure that we're looking for information that's all about helping them to cope with their life. Giving approval or disapproval. So we don't want to say, oh, that's really good. And so you're probably thinking, well, what do you mean I can't say that's good? It is actually not therapeutic. When you say, that's good, that's great that you're doing that, by giving approval, that makes it really difficult for the person to ever tell you anything that's negative. They will always just want to tell you good things. They'll want to tell you just what you want to hear or what they think you want to hear. They're not going to tell you the truth. So that's why we don't give approval. We can talk about that again in post-conference. That would be a great topic. I've got some examples about that. We don't want to give disapproval either and say things like, well, I wouldn't do that if I were you, or that's really bad. We don't ever want to do that. Even if that's what we really think, we don't want to say that. We don't want to give advice. If we are giving advice and telling people what to do, it makes them into a very non-powerful person, and it really conveys the message that you just don't think that they have the ability to make their own choices and decisions. Like, you think they're a very ineffective person. And so then that really fosters dependence. So we really don't want to give advice. Asking why questions. So if you ask a why question, then people usually end up feeling very defensive. So if you say, well, say if we were meeting in a classroom and you came late, and I looked at you and said, well, why did you come late today? You're going to automatically feel defensive. And then you're going to start saying, well, my kid overslept, and then I had to bring them to school, and then he threw up on the way to school, and I had to go back and get him a change of clothes. Then you get angry and defensive. So we don't ask, why did you cut yourself? Why did you start drinking again? Why did you take methamphetamine? We don't want to ask why. It makes people angry and defensive. Cultural considerations. Again, we always have to think about who to communicate with, if it's a male versus female. There are some cultures that maybe it would be difficult for a male patient to communicate with a female. We have to think about eye contact, what's acceptable, touch, and just other cultural filters, forms of bias or prejudice. So we talked a little bit about culture already. Preparing for the clinical patient interview. So again, let the patient kind of set the pace. The setting, try to make sure that it's calm and private. For safety reasons, you should be seated closest to the door. If you're sitting down, try not to sit on the patient's bed, but in some rooms there's no chairs, so that makes seating a little bit difficult. But sitting down actually is helpful because it really gives the impression that you're there to stay and you're there to really listen to them. So introduce yourself, your role, initiate the interview. Sometimes it's just helpful to say, is there anything you would like to talk about today? What's on your mind? How's it going for you here in the hospital? What are your plans for discharge? And just, just initiate with any of those things that can be very helpful. If a person has been there for a couple of weeks already, or maybe even for a month, it's probably not helpful to start with, why did you come into the hospital? Because that was a while ago. So it's sometimes maybe better to try to stick to the here and now and take it from, you have the ability to look at their chart and kind of see why they came to the hospital, and try to help them focus on what's going on in their life now and how can they help themselves to get better. Things to avoid: arguing, minimizing, or challenging the patient, giving false reassurance, by saying something like, I know everything's going to be okay for you. We really, unfortunately, don't know that everything is going to be okay, but of course, we're there to help the patient and walk with them in their journey. We don't want to interpret or speculate. This is especially tempting when a patient is talking about a friend or a family member or a significant other. I know that I read this sometimes in students' process recordings, and they'll kind of try to interpret like the behavior of the family member. You really can't do that, so just stay away from that completely. And again, we don't want to probe into areas that the patient doesn't want to discuss. We don't want to try to sell the patient on accepting treatment. Unfortunately, I do see that happening, not so much with students, but more or less I've seen that with staff members saying, take your medication and then you'll get out of here quicker. It's like, it's really not very therapeutic. You don't want to ever join in and attacks the patients that a patient might launch on others, whether it would be staff members or other patients. So if a patient's really being annoying on the unit and your patient is saying, oh my gosh, that patient's got such annoying behaviors, they drive me crazy, it's not okay for you to say, yeah, I know they really drive me crazy too, or criticizing other staff members. So after all this tactics to avoid and things not to say and what to say, you might be thinking, oh my gosh, I am going to say the wrong thing. So I just wonder how many of you are actually thinking that at this point. And there is a nice little paragraph just about that on page 138. It says, saying the wrong thing. And honestly, students are very likely, yes, to make a mistake and say something that's not therapeutic, but as that paragraph points out, the patient can tell that if you are genuinely concerned and trying to help them and trying to, again, walk with them in their journey, they're not likely to respond in a negative way. They know that you're trying to help them. And as a matter of fact, I've had some patients actually be very forgiving of students who have made mistakes in therapeutic communication because they were students, and the patient knows that you're a student, and they're actually quite forgiving about that. So don't worry about saying the wrong thing, even after studying all these therapeutic and non-therapeutic techniques. It's very unlikely that you would ever say anything that is going to be detrimental to the patient. So attending behaviors, eye contact, body language, personal space again, the quality of our voice, just to make sure that sometimes when people get anxious, their voice level kind of, people talk faster, they might be a little bit more high-pitched, but that might make the patient more anxious. So we just have to try to be aware of our voice quality. And again, clinical supervision really fosters growth, and that is super helpful when you're first learning therapeutic communication skills. And the process recording, so that is an age-old activity that psychiatric nurses have been doing since forever. I've had to do process recordings when I was in school, and I graduated 38 years ago, and I had to do process recording. It's been around for a long time, but it is truly, you'll do it in clinical, it is truly the best way that you will learn how to communicate more effectively, because you'll be able to look at and analyze your own communication. It is a really great thing for identifying patterns. So if you tend to be the person who is always trying to give approval and say, oh, that's really great, then you might have to take a look at that and say, that's not very therapeutic. I should really be doing something different. So last slide, audience response question. Oh my goodness, 2 hours, yikes. As a nurse assesses a new client, the nurse makes sure the door remains open. Which type of communication factor is this action? environmental, relationship, or personal. I hope you picked environmental. Okay, that is the end of Learning Plan 1. I'll see you at Learning Plan 2.